Good afternoon, ladies and gentlemen, dear guests. My name is Mirza. I am pediatric cardiologist from Sarajevo. And it's a great privilege and honor to be here and to be able to present our work and here in Athens, with city with such medical, historical, scientific heritage. So I would like to present several cases that highlights both clinical implication and diagnostic challenges of very rare congenital coronary anomalies, Al-Kappa syndrome, that could be remained and hidden for many, many years, even it is presented mostly in infancy period. So let us beginning briefly review our knowledge about Al-Kappa syndrome. So even it is rare, Al-Kappa syndrome, when it present with dramatic and life-threatening consequence as arrhythmia or infarction or sudden death. So it presents origin of anomalous artery based, of course, on embryology. And question is, how many teeth are there? Too many, but for our congenital point of view, Al-Kappa syndrome is most important. So in some humoristic funny, we can look at Al-Kappa syndrome like two different types of thieves, like Al Capone and Robin Hood. So first of all, we have to know normal coronary perfusion and to know that reliance, as we all know, that during the neonatal period, there is no symptoms because of liquid pressure in pulmonary artery and aorta, and with antegrade flow into left main artery. But after that, after 4 months of life, change happened because of decrease of pulmonary pressure and retrograde flow into the left main artery, and usually during the infant period there is a manifestation, even because of huge, extensive collateral circulation development. In some cases, in 10% or 50% cases that survive this period, they can happen to live more years and years and adult change. So the clinical manifestations are different because collateral circulation. This collateral circulation based on the enters to the low pressure system with on high resistant pathway to the myocardial microvessels, and also one low resistant pathway to the pulmonary artery, both leading to the left ventricle hypoperfusion. So clinically, it could be manifested with myocardial ischemia and infarction of left ventricle dysfunction or congestive heart failure, or even with a preserved cardiac function. As we said, 85% are presented in infant period, but we also have to know that our diagnosis is based on heart failure signs, murmur, ECG, and the left ventricular dilatation and dysfunction, as we see, but also our real diagnosis are on the end are based on imaging echo, MRI, CT, or CATs. So when we talk about echo, there is a simple sign that we can recognize Al-Kappa, but also we have to know that there is a trap with a dropout artifact, so we have to use both 3D, 2D color and PV, because of if you use PV Doppler, there is a high coronary flow velocity in systole, then in diastole on PV on the right coronary ostium and coronary vessels. So CT, MRI, and CAT will be helpful, and also there is a distinction between these two infant and adult type, if you look at for clinical echo or ECG findings. The most worst thing is not to recognize Al-Kappa and to diagnose it as idiopathic dilated cardiomyopathy in infancy and putting child without proper treatment, and child will die during the next period, couple of weeks probably. Our goal is to re-establish dual coronary symptoms. There are several types of surgically, and also initially there is anticongestive medication and post-operative treatment as well, and also having in mind a specific problem that can occur during this period. Mortality is up to 20% and normal cardiac function within first year or after operation. Post-operative evaluation of cardiac function post-surgery based on long-term spectral echocardiography or MRI, and also on the end I will try what is based of our presentation is to introduce how a clinical reporters is Al-Kappa syndrome. Case number 1, so we have 4 cases. Case number 1 is like a straight cases, 4 months female infant, poor feeding, seizures, arithropathy of 4 weeks prior admission, and hemodynamically compromised and required mechanical ventilation and inotropic support with left ventricle dysfunction. This child was with anterolateral infarction, left ventricle dysfunction, and it was she was operated during this week and during the follow-up in the last 6 years, actually 7 years, she is doing fine. So second case, sorry, this is a cat of this child, and also second case is similar by the first sentence. This is 4 months old male patient with sign of congestive heart failure, dyspnea, and feeding difficulty, but unfortunately, problem with post-operative because of aortic anastomosis of left main was obstructed. Tube graft was occluded, so team was decided for stenting. So first stent of left main doesn't work, so they put because of residual stenosis in the proximal portion of the left main. So second, the drug-eluting stent was putting. And this is probably the youngest Bosnian guy with coronary stent. After 27 years, removing tracheostomy cannula with satisfactory myocardial and respiratory function, and 3 years after that we performed diagnostic CAT and later on follow-up, and this is a child of 8 years now, doing fine. Third case, we can call that BOI is immunized because immunization saving lives. This is a 3 years old male patient suspected to the post-factum myocardial lesion, admitted for cardiac evaluation due to murmur and morbilliform rash, and we find out that child it was suspected like post-vaccinal myocarditis, but in fact it was after echo and MRI proper diagnosis was diagnosed, and child was operated in Vienna. This child, and after that during the last 5 years he's on only follow-up and doing fine. And the last case is a case of athlete. Teenager girl, and as we see, there is 70% of all cause of sudden cardiac death in athletes belongs to the anomaly of coronary artery, and this is 12 years old, presented with cardiac arrest during the training with previously preserved left ventricular function, and this child was observed by a cardiologist, but without notice of Al-Kappa. She was looking for cardiology only for ECGs and for auscultation, and without any symptoms. Well-trained girl having more than 3 trainings per week without any symptoms, and then crash in one training, needing for CPR, defibrillation, intubation, complete mechanical ventilation, and she has a luck because of trainer is nearby our clinical center, so she needs probably less than 2 minutes to come to our institution. Previously, beginning with CPR of one of father of other guys is a doctor, so he started with CPR until ER came and then sent it to our ICU. And when we look at the echo, we notice the preserved left ventricle function, but we notice the huge dilatation of the right coronary artery, more than 6 millimeter. A CT scan schedulally performed. We saw also interseptal collaterals, huge interseptal collaterals, and we based diagnosis on all these ultrasound findings and perform CT and finding that it is our diagnosis. And you can see how huge right coronary it is, 6.7 millimeter without visible left coronaries. She was operated, and after operation, 6 days in ICU. It was a question mark about ICD, so we can discuss about need of ICD in this patient. If we look for guidelines, probably we will say yes, ICD is certainly is option. But when we look at that, we resolve the problem of ventricular arrhythmia, then we don't need ICD. So we did agrees also with people, our colleagues from Belgrade, and also our colleagues from Vienna for Allgemeine Krankenhaus in Austria. Also, we agreed not to put ICD in this patient. So what is our takeaway messages is Al-Kappa is rare, deadly without treatment, but curable. Coronary steal is central mechanism. Early diagnosis save lives. Early interventions has good outcome, and always know who is stealing your blood, putting these thieves behind the bars where they belong. Thank you very much.
Thank you very much, Dr. Halimic. I appreciate the title. Really, it's 1,000 faces, and one of the faces is also pulmonary hypertension.
Yeah.
I had, in my career over, the past 40 years, 5 cases, and the triggering factor to put, the diagnosis was, the pulmonary hypertension during pregnancy. Mm. And probably, the last case, this 12-year-old girl who developed cardiac arrest during training, probably, she developed a pulmonary hypertensive crisis.
Yeah.
This one, we published in chest, and it was, accepted. The last case, I operated, 18 years old, pregnant lady, and then everything, became very evident with the beginning, during the first 3 months of the pregnancy, because there is an increase in the volume, and probably all this hormonal mechanism, can trigger the pulmonary hypertension. Don't forget also this one.
No, of course. And also there is also secondary findings when people operate something simple like VSD to find Al-Kappa as well as so there is a operative program changed.
Yeah, very good. Okay. There is another question. Yes.
Can I just make a comment on this and say that the most lucky patients are the patients that have a dominant right coronary artery. Okay.
Yeah.
Number one. Number two, it's very rare to see a child 12 years old or an adult with Al-Kappa, but it can happen. And I think the message we need to take in consideration is 2 issues. When you examine these patients, if you don't see the bright papillary muscles, okay, you need to start thinking what else this can be. So the differential diagnosis in a baby, let's say 2 months old, when you have the pulmonary resistance drop, you don't have the brightness of the papillary muscles because you are still in the beginning of the condition. Your differential diagnosis seeing a patient with a high ejection fraction heart failure condition. Okay, must always go to 2 diseases only. The one is heart kappa, and the second is a vein of Galen. These are the only conditions that will give you this high ejection fraction condition with a normal heart.
Yeah.
And then you need to find out what is happening. Many of these children can present like a VSD condition, and you try to find the VSD and you don't find it, and you think about a window and you don't see a window, okay? So a PA window, so you need them to go and thoroughly examine the coronary arteries. But I believe today that most of the pediatric cardiologists know how to see coronary arteries by echo. And the machines now that we have are more excellent. And I'm just saying these 2 issues, okay, and I pay tribute to my teacher, Jan Marek, because when Jan Marek came to Great Ormond Street, he was the first person who told us how to see the coronary arteries by echo. And this was 2005. And we stopped doing angiographies. We don't do angiographies nowadays. We only do an echo, and we can see the coronary arteries.
And just to mention that we saw the incidence of very rare congenital, but when I'm looking back, when I calculate, I should be probably until my retirement not to see any L kappa so far, because I was diagnosed more than 7. So, but the statistics is something else. So that's because of that. I always try to look at coronaries, even if it's something simple for looking for. So in every neonate, in a second, third days, just to look at for coronaries. So it is very, very important, like everything else.
Important message. Thank you very much.
Thank you very much. Bye.